So, I've been an advocate for interventional pain for many years. And so I remember 15 years ago, people would say, well, those guys are cowboys, they're too interventional, they should be doing more opioids. And it turns out we were probably right, and think that we swung too far on the opioid side, and people like myself never were big advocates of high-dose opioids. I think where we're going is going to be exciting. For example, I've been involved in several projects the last few years. I was involved in the DRG project, and I was involved in the high frequency project, and I was involved in the feedback loop project currently, and I was involved in the burst waveform project. And all those things have turned out to be phenomenal changes for patients. Not all patients. Where we're going to go in the future is being able to select better who is a candidate for different things. And that might be by urine biomarkers, which I'm working on right now with a guy named Joshua Gunn, who's a PhD out of Australia. It may be by just looking at large registries to figure out who did well with what. So I think we have competitive companies, but long term, if we can get where we can identify without company marketing, but we can identify who has the best chance of a good outcome with any particular device, we'll do much better. The other place we're going is minimally invasive spine treatment. I've been very involved with intraspinal spacers and lumbar decompression. Now we're looking at some other things to treat the bone. And then lastly, I think we'll be involved in maybe some new arenas of medications for pumps that are non-opioids. There's a big need there. So all those areas I think are interests of need that we are uniquely positioned as interventional physicians to help with. I get really excited when I see young physicians doing well. And so, some words of advice. I think one is your first job may be not the right job for you, and you may change 2 or 3 times. Don't be discouraged. Find the place where you can do the best patient care. Obviously you want to make a living, but patient care has to come first. You will make a good living if you give good patient care. Secondly, don't get jealous of your colleagues, help your colleagues. And so much people get bogged down in professional jealousy. It may help them today, but it'll hurt them long term. You're much happier if you can enjoy your colleagues doing well in our areas, and I think that's very important. And thirdly, I think if you always have the patient's best interest in mind, you're going to have a great long career. And so I've told a lot of young folks, my priorities have always been God, family, work, and it's got to be in that order for me. And I'm not telling them they have to do what I do, but if they don't have a mantra that they live by, they're going to get confused. And when you get off that mantra, whatever your mantra may be, you're going to go down a bad path. And so you got to reset yourself every now and then. I think our message should be that really we're here to help foster the field, foster young people, and not here to be in any way an adversarial society to others. Well, again, I want to make sure that I tell you that I'm pro other societies. I've been a member of NANS for many years, on the board of NANS in the past, and president of the INS. So we're not in any way anti any other society. And for example, that's a great device-based society. ACEP, a great interventional-based society who has done a lot of great work on reimbursement and legislative changes. Those are not our calling. Our calling is to create really an arena for people who have ideas to share them with each other and develop new research-based projects. That's one of our major goals, is create new research. Krishna Chakrabarthi is leading that with Kate Meacham, and they're doing phenomenal work to get that going. We also want to take people out of fellowship who maybe didn't learn as much as they should have about one area, and have them find somebody who can help them foster them to the best outcome. If you have a new device that you want to try out, we can help you find research sites, for example. We have a lot of folks that would have interest in getting involved in a central IRB and going forward. So all these things, I think, are going to be kind of a different way to look at specialties and societies. Our most important rule to me, though, is that we don't want any professional jealousy or infighting. That's been a problem with some societies in the past, and so if we see that, we may actually vote you out of our society. It's like being cast off the island, right? Hopefully we won't ever need to do that, but because we hopefully will attract people who want to be collaborative. But if you come in and you're not a very nice person, we probably wouldn't want you in this society, because you're here to help your colleagues, not to fight with them. And so that's one of our major goals. And will we achieve that? I think we will. We'll find out, though. So, again, we've got a lot of great leadership folks there. Dawood Saeed, Corey Hunter, you mentioned Sean Lee, Erica Peterson, John Carlson. We got a lot of great folks involved in that. And there's certainly our websites there. Our meeting in July is a great way to get involved. And then we're going to be at different meetings around the country as well. We're going to have a large representation at INS Sydney coming up next month. A lot of our colleagues are here. And again, we want to be collaborative with other societies as well. So we try to be active in each of the other societies, and instead of being an opposing society, being a collaborative society. And so I think, any young person who wanted to get involved could contact myself or Dawood Saeed, and we'll be glad to get them involved if they have the right ambitions in mind of helping the field. No, we've created an international chapter of Aspen, and we don't have a particular country. We have an international chapter, and we have a doctor named Paul Verrills out of Australia, out of Melbourne, who's a very close friend of mine, who's been a leader in research and development, and he's leading our international efforts right now. And I think that's going to grow and become important as well. So I think we'll see this movement take hold. And Paul has been very interested in training the fellows in that part of the world. He and I are doing a course together in June over in Australia for the Asia Pacific rim of young folks. So we're going to be doing DRG and spinal stimulation, all those things there. So I think that's the beginning of a good launch of that aspect of our society. We had so many young people come to me and say, I can't get on a committee. Can you get me on a committee? Well, of course, I'm past president of INS, but I have no power to get on a committee at NANS anymore. I was on the board there for years, and it's just sad that you have young, ambitious people who can't get involved. They want to be involved. And you say, no, if you come to our meeting for 5 years and meet everybody and network, you might get on a committee. To me, that makes no sense whatsoever. And then I go to dinners and there's people who say, oh, that doctor's horrible, he's awful. And I know the guy and he's not awful, and it's professional jealousy, and I don't like that either. So I really want people to try to help each other. And so that's why we really founded this. It happened when I was walking into Caesar's Palace one evening with Dawood, and I said, we got to do something about this. And so it just came to me one night, truly. Well, I think, I would leave the viewers with the thought that, when we were looking 10 years ago, we had no level 1 data. And so we would go to meetings and we say, I do this because of this, but we had no real good evidence. Now we're in a really great spot. We got evidence coming now for both implantable devices, for minimally invasive spine, but we can't rest on our laurels. We have to continue to study things. So if there's an unfortunate approval of a device with no study, which happens sometimes, I think we should then ask those companies to go do a study. Because I don't think we should be using devices long term unless we have evidence that they work. So to me, that's important. And I think we need to keep re-examining safety. I've been involved in dorsal ganglion stimulation, and we just did a paper on the safety, and it's actually quite good. But that's because of physician training, right? So we have to look at safety and efficacy long term. So I would encourage my colleagues to gather evidence, and in their own practices, they should track outcomes in some fashion, because they can see how they're doing. Because if something works in my hands, it may not work in yours. And if you are not very good at something, don't do that. Send that to a colleague somewhere else. And so I think we need to keep re-examining the field and re-examining our individual practices. So Dr. Chapman in New York and his group, he's got a phenomenal group. He's done some great work recently on the use of DRG for axial back pain. And his results in his palate study has been phenomenal. And we have Dr. Kelleward over in Holland doing something on discogenic back pain. So the targets have been T12 and L2. And I'm hopeful that and I'm going to visit Dr. Kelleward in June. I'm speaking at the French Neuromodulation Society in Bordeaux, and I'm going to go from there to the OR in Amsterdam. And I think we really should collaborate, for example, between Holland and New York City and West Virginia, and do some joint studies and look at populations because that type of collaboration is important. So I'm looking forward to working with Dr. Chapman and Dr. Kelleward on that issue. Just a word about my race this summer in the Badwater 135 ultra distance run in Death Valley. I think it's gonna be my greatest challenge. I'm really excited about this. About 40% of people don't finish it, so you have 48 hours to go 135 miles, and starting at minus 385 up to 8,900 feet at the portal of Mount Whitney. So to me, that's going to be my next big event. Is that I get a lot of focus on that right now. In regards to what I'm working on in studies for devices, though, which is what you asked me, but the Badwater thing is on my mind pretty heavily. I'm working on the closed loop study with Saluda right now, and I've been working closely with my colleagues there. We'll be presenting that 1-year data hopefully by NANS of next year. I think we'll see the 1-year results. We saw Dr. McHale do a great job presenting the 3-month data at NANS last year. We're going to see if we can maintain that durability-wise and present that information. I'm working on something called the BOLD study, which is using low energy bursts, and that's with Abbott, but we actually have got down to 1.8 hours a day to get, and 43% of people getting the same result as someone using 24 hours a day. And I've always had this theory, there's too much electricity going to the cord. And if that's true, you can use a non-rechargeable device maybe for up to 8 or 9 to 10 to 11, 12 years based on that low energy. So I think that's very exciting. I'm working on some new studies with the intraspinal spacers with Vertiflex, and working on some lumbar decompression with Vertos on the Mal procedure, and looking at the next level 1 study group in that, multi-center. So both those devices are getting more evidence, which we need, as I pointed out. So those are things that are exciting me a great deal at the moment. I think we're looking at new indications for DRG, peripheral neuropathy, looking at diabetic neuropathy in that indication group, discogenic back pain, post-Lamy syndrome, and DRG. So all these projects are going on, and that's how we need to do things. We need to stagger those. We'll be doing a new multi-center project on radiofrequency ablation, lumbar facet, which is greatly needed because we complain about European studies, but we don't do our own. So we're going to do a multi-center study on that prospectively. I'm going to lead that hopefully over the next 6 months. We'll get that started. So again, as you can see, there's a lot of projects, and we can't do them on our own. We have to have some great colleagues, and fortunately, we have that going on right now in America. We have some great colleagues here wanting to really focus on research and development. So, I think closed loop technology could be a phenomenal thing for our patients, and it may not be. We have to go and see how the study turns out. So we'll be giving details to the viewer over the next, hopefully 6 months. Closed loop technology, what it does, it measures, first of all, the system measures the ECAP, the action potential in the spinal cord to the neuron when you deliver electricity. And then in the open loop, it measures it, and you can reprogram it on the computer. Your rep can do that, or you can do it as a physician. But closed loop, it basically responds itself. The device responds to that ECAP. And it keeps someone in the therapeutic window much more of the time. For example, if you're on a non-paresthesia-based system, you may be given way too much electricity, way above the therapeutic window, and you may never be in it. If you're given a paresthesia-based system, it may hurt you when you turn it up too high. You may stay below the therapeutic window. So theoretically, closed loop keeps you in that window, so you get more analgesia, is the theory. I believe that is going to be true. Now the question is, do we need that for some of the newer waveforms? And we need to show that next. So I think this could be a major breakthrough in the field, but we need to really prove that in level 1 data. So when you interview me next year, I'll give you the answer to that. I don't want to assume it's going to have great 1-year data because we haven't seen it yet. So that was a very complicated question. So let me I'll put it in simple country terms, like where I'm from in West Virginia. In open loop, we program the device, and we give the patient maybe some small ability to adjust it. There are some sub-paresthesia-based waveforms. For example, I've done the burst DR waveform quite a bit and studied it, and most people don't have any paresthesia there, so they don't need to adjust anything. So that's one subset of patients. They don't do any adjustments. If they're doing well, that's very good for them. If they have something they have to adjust, then that's a variable. In closed loop, it adjusts itself. So I think there's no question that these two things are better than this thing here, where patients have to continuously make changes in their device, but we don't know which of those two are going to be the best. But theoretically, both those will work quite well in patients long term. We need some comparative efficacy studies someday, where we compare different therapies. The only study like that so far was Jose de Andres in Spain, looking at Nevro versus Medtronic. But we haven't had a lot of comparative efficacy studies. But that's where we probably need to go long term. I still think the urine biomarkers, though, may have a great deal to do with this, predicting who might do something long term. That's probably 10 years away, though. We have to learn what they mean, and we'll get there. Well, I do think that, we're in a great, I'll tell young people all the time, they're in the golden age of neuromodulation. I think we're getting ready to get into the golden age of minimally invasive spine, too. So there's a lot of companies out there that, many of which are in their startup phases, that will allow us to do less and less invasive things to the spine successfully. And so of those, the two right now that have had the best success in many people's practices is Vertiflex, the intraspinal spacer. It certainly is much better than X-Stop, because X-Stop you had to take muscle down, it's a large device, whereas with intraspinal spacers like Vertiflex, you actually can go straight to the space, go down to the lamina, and it's less invasive, but also seems to work much better. Mild procedure, we take some ligament off and open up the spine without a major decompression, so the trauma there is much less to the person's spine, and potential things like bleeding, infection are less. I think those are the first two things of what's coming. I think there'll be many more things like that. And again, I think for young physicians watching this, get yourself involved in those early studies, because that's how we're going to really make progress. And so that's a combination of physicians, industry, venture capital investors. I mean, it's a complicated thing because none of us can do it on our own. It's got to be a collaboration of multiple people to advance this type of thing. So actually, we are going to be doing some hands-on training. That wasn't my idea. It was the idea of some of my colleagues. We're going to have our first cadaver-based course. It's going to be advanced, so it's going to include things like intraspinal spacers and mild and DRG and all those things, hopefully. And it's planned for this fall. in Phoenix, Arizona. Dr. Saeed's running that course, and I think he's hoping to bring a great faculty of a lot of the folks we've already talked about on this webcast today to that faculty, and is going to give people a chance to, maybe you did some of this in fellowship, but you didn't do a lot of it, to give people a chance to do a lot of hands-on work with people that are truly experts at it and ask questions and interact. So that will be coming, and there'll be an announcement about that probably in the next few weeks. I think the planning is almost completed, but I think it's going to be September 2019 and out in Arizona. So, the question being the simulation, in anesthesia, it's had a big place, right? We have a room, and the person codes in the simulator, and my daughter's been in an advanced nurse training school, and same thing, they have nursing simulation, that they get their clinicals before they go see a real patient. We have not had a good simulation tool that I've seen in the area of spinal cord simulation or dorsal root ganglion simulation yet. I think there's a major role for it once someone gives me something that is helpful to training a doctor. So far, and I know you're involved in some of that, I haven't seen one and maybe I just haven't seen it yet, but I haven't seen one in the spinal cord simulation, DRG type environment that would simulate something enough that it could help me train someone. I'm much better off currently on a cadaver. Would I prefer a simulator? Absolutely. Less radiation, less risk of biohazard. I mean, everything about it is better. So if someone comes up with that, I'm on board 100%. What about, think about things like mapping. If you think about someone doing a procedure in the brain, they'll get imaging before, and they can do some imaging mapping without so much radiation, right? In the spine, there hasn't been enough really resources financially to do that, but there's no reason why I think neuroimaging and mapping couldn't improve to lower our fluoro risk. And that's another area I think should really be looked at going forward, because the risk of fluoroscopy to physicians isn't minimal. It's a big risk. And so if we can do things with neuroimaging that would allow for that type of mapping, it would be better too.